Hi, this is Nursing It, and you're watching a recorded discussion on neurological disorders. The nervous system is divided into the central and peripheral branches. The central nervous system includes the brain and spinal cord. These are protected by the bones of the skull and spine, as well as a fibrous membrane called the meninges, and they're bathed in cerebral spinal fluid, or CSF. One additional protective measure of the central nervous system is the blood-brain barrier. This is a cellular defense mechanism that prevents antibodies, toxins, and macrophages from entering the brain during capillary exchange of gases, nutrients, and waste products. The peripheral nervous system includes 31 pairs of spinal nerves, 12 cranial nerves, and the autonomic nervous system. The autonomic nervous system is then further divided into the sympathetic and parasympathetic. The sympathetic nervous system is referred to as the fight or flight system, and this is mediated by the excitation effects of norepinephrine and epinephrine on adrenergic receptors. The parasympathetic nervous system is often called the rest and digest or feed and breathe system, and this is mediated by the effects of acetylcholine on the muscarinic and nicotinic receptors. And acetylcholine is either excitatory or inhibitory, depending on the location of the receptors. Assessment of the neurologic system includes establishing a baseline and performing interval assessments for change. The sicker the patient, or greater the risk, the more frequently the assessment is indicated. Components of the neurologic assessment include checking mental status. This can be done using the AVPU scale. Are they alert? Do they respond to verbal, physical, or are they unresponsive? This is also sometimes referred to as level of consciousness. Other terms used to describe mental status are conscious, lethargic, stuporous, and in a coma. These terms are more subjective than AVPU or GCS, and you should be cautious of using them because they mean different things to different people. Also be cautious of using the abbreviation LOC, which really stands for loss of consciousness, but is often misused as level of consciousness. The Glasgow Coma Scale, or GCS, is a more objective approach to quantifying mental status. It scores patients on best eye opening, best verbal response, and best motor response. Scores range from 3 to 15. An unresponsive patient would receive a 3, and a patient with no deficits would receive a 15. What's the most important about the GCS is knowing the patient's baseline and monitoring for acute changes in GCS, and then consider a patient with a GCS of less than 8 to have lost the ability to protect their airway. Cranial nerve assessments can be formed quickly with minimal tools. Assess a sense of smell, vision, pupillary reaction, extraocular movements, facial movements such as smile, puffing out the cheeks. Look for symmetry, check for sensation, hearing, have them open and occlude their teeth. Check the tongue and uvula to make sure they're midline. Have the patient say ah, swallow, shrug their shoulders, and turn their head from side to side. Note any nystagmus, asymmetry, the inability to follow commands, any loss of smell, hearing, blurred or double vision. Assess cerebellar function by observing the gait and balance. Romberg test is a good test for this. You can also have them touch their finger to their nose and your finger and alternate locations of your finger. You can have them run their heel from their knee to their toe along their shin. Peripheral nerves are assessed for bilateral strength, sensation. We do this CSMTs on the hands and the feet, color, sensation, mobility, temperature, and we also check pulses at the same time. You can also check major muscle groups such as the biceps, the triceps, and the hip flexors. And then reflexes. So deep tendon reflexes can also be assessed as part of the neurological exam, especially in somebody that might be on, let's say, like a magnesium drip, or somebody who you're worried might have increased deep tendon reflexes. If a neural problem is suspected, the Cincinnati Stroke Scale helps determine if a stroke is likely. There are 3 components to this stroke assessment. The first one is facial droop. When the patient looks at you and smiles, Do both sides of the face move symmetrically? The next one is arm drift, and you're looking specifically for pronator drift. Have the patient sit upright, at least semi-Fowlers, if not full Fowlers, and extend both arms out in front of them, away from their body and not resting against any side rails or objects. The palms should be facing upward. Have them close their eyes while you count out loud to 10, looking for any pronation of the hand or drifting of the arm. So we're looking for the hand turning over, like palm angling downward, or the hand drifting. And even just a quarter or a half turn would signify positive response. And then you're looking at speech. So give them something to say, and you're looking for clear dictation as well as memory of what you just told them. In this example, we had asked this gentleman to say, you can't teach an old dog new tricks. And he says, you can't teach an old dog new tricks, which obviously then he has some slurred speech. Head injuries are of particular concern to us because quite often you can't see any sign on the outside of what's going on the inside. Head injuries are classified as mild, where the GCS is 13 to 15, moderate, where the GCS is 9 to 12, or severe, where a GCS is 8 or less. Injuries can be diffuse, such as a concussion or a diffuse axonal injury, where widespread areas of the brain are involved, or localized, like a contusion or a bleed, where there's just a specific portion of the brain that's injured. And the signs and symptoms are going to be very specific to the location and the type of injury that occurred. Common signs and symptoms of head injuries include neurologic symptoms such as headache, nausea, dizziness, fatigue, difficulty concentrating or performing fine motor function. A bleed is more likely, though, in patients who have significant risk factors, such as an age greater than 65, or someone who's on antiplatelet or anticoagulants like aspirin or Coumadin. If they have a concerning injury or findings, like a Glasgow Coma Scale less than 15, 2 hours after the event, so initially maybe they're a little confused, but they really should clear. Or they have open or depressed skull fractures, more than 2 episodes of vomiting or projectile vomiting, evidence of a basilar skull fracture, which would be like Battle's sign or raccoon eyes, or they lose their sense of smell. Those two would be signs of a patient who has a significant mechanism of injury or a potential bleeding inside the brain. All of those are indications to receive a CAT scan. Some notes on specific types of head injuries. Epidural bleeds are arterial, and they involve usually trauma to the temporal region of the brain. The classic presentation for an epidural bleed is loss of consciousness with a return of a lucid interval, and usually they have significant head injury signs and symptoms like pain. And then a second loss of consciousness. These are really significant because, again, it's an arterial bleed, so it's bleeding fast with a lot of pressure. Subdural, however, is venous, and it can be acute, subacute, or chronic. The risk for subdural bleeds really increases with age and alcoholism. Diffuse axonal injuries occur due to massive shearing forces being applied to the neurons, and often these injuries are rotational or sudden acceleration or deceleration injuries. Sometimes no external injury is even evident on the person. And then second impact syndrome, and this really is important for us when we're dealing with kids, especially if they're in sports. So this occurs if the brain sustains a second injury before the first one heals. And this is why students and athletes should always receive clearance from a provider prior to re-entering any sort of impact sport, because it can lead to death. So there's already some swelling in that area of the brain where like the first concussion or head injury occurred, and then a second injury occurs and it creates this neuronal shearing, which can lead to either permanent neurological deficit or death. A brain attack or cerebral vascular accident or stroke is when there's an interruption in blood flow to the tissue of the brain. So just like the development of atherosclerosis throughout the arterial system of the body and the heart, the arteries of the brain can become diseased due to non-modifiable risk factors like age, gender, and ethnicity, and modifiable risk factors like smoking, hypertension, high cholesterol, and drug use, especially stimulants like cocaine. People with arterial disease are susceptible to clot formation, just like blood clots in the heart or other places in the body, while atrial fibrillation increases the risk of an embolus. The use of anticoagulants or the presence of an aneurysm or uncontrolled hypertension is the cause usually of a hemorrhagic stroke. So we can have an acute ischemic stroke, we can have an embolic stroke, or we can have an hemorrhagic stroke. And really the cause of it depends on the patient's history. If symptoms resolve in less than 24 hours, it's classified as a TIA or transient ischemic attack. And if it lasts, the deficits last greater than 24 hours, then we consider that a CVA or cerebral vascular accident. The specific deficit is going to depend on the location of the brain which was affected. Safety and airway are always going to be our highest priorities in the acute and subacute management of patients experiencing strokes because of the increased risk of aspiration and loss of airway. It's important when they get admitted, they come to the floor, always get that speech eval before you feed them, and don't delegate that first feed. You really want to be there to watch that to make sure that they don't choke or aspirate. Whether we have an injury, a stroke, a bleed, an infection, obstruction, or masses, these things can all cause an increase in the amount of fluid or pressure inside the cranial vault or inside the skull, and this leads to potentially life-threatening problems. So intracranial pressure monitoring can be performed, and up to 15 is normal, but neuro assessments really are paramount because you may notice some subtle signs and symptoms before you really notice a significant change on the monitor. The signs and symptoms of increased intracranial pressure, again, are neurological. So nausea, vomiting, headache, and then changes in our Glasgow Coma scale, so changes in speech, motor, and eye function. You also might notice papilledema, which is edema of the optic nerve, and we see this with brain tumors as well as head injuries or anything that increases intracranial pressure. Pupillary changes, so initially they may be kind of sluggish, and then you might see unequal pupils, or one may become fixed or dilated. Altered mental status, so with that decrease in Glasgow Coma scale, as well as posturing. So initially we have flexor posturing and then extensor posturing, and then seizures and coma also are possible. Infants, because they don't have joined sutures, experience slightly different signs and symptoms like bulging fontanelles. They may get this really high-pitched kind of keening cry and experience projectile vomiting. Cranial suture separation is also possible, so the whole head gets larger, so you see this increase in head circumference, and they don't feed well. If hydrocephalus or an obstruction of CSF outflow is the cause, then the head itself gets very large and the eyes look like this kind of sunset eye sign. So Cushing defined this triad of vital sign changes that occur with increased intracranial pressure. And essentially they're the opposite of shock. So with shock we have hypotension, tachycardia, tachypnea, but with an increase in intracranial pressure we have hypertension, so an increase in systolic blood pressure with this widening pulse pressure. So there's a huge an increasing difference between the systolic and diastolic. And then the patient becomes bradycardic and then will develop these irregular or slow respirations. Other things you might see with this would be signs of herniation, like a blown pupil or that posturing or seizing. And the treatment for increased intracranial pressure includes osmotic diuretics like mannitol or hypertonic saline, surgical decompression, and then if it's hydrocephaly, then we want to do CSF drainage or place a VP shunt for obstruction. If there are clear signs and symptoms of herniation, we would increase the respiratory rate by 5 until we saw a resolution of the posturing or the pupillary changes. Remember, we don't hyperventilate anymore because we really need to keep a careful control over the end-tidal CO2, and we don't want to cause like a respiratory alkalosis, which would actually make them worse. Spinal cord disorders or spinal disorders such as degenerative disc disease, spinal stenosis, herniated discs can cause chronic pain, and the pain tends to radiate along dermatomes from the spinal column or the nerve root compression. It's important with the management of these patients that they have a full workup to rule out any other possible causes, and then they're typically treated with muscle relaxants, pain medication, physical therapy, and then even complementary or alternative medicines, chiropractic, acupuncture, acupressure, massage, things like that. It's important to provide education to patients about safe use of muscle relaxants and opioid pain medications, especially patients who have some sort of neurological issue going on. Spinal cord injuries can also occur from acute trauma to the cord, the bones, the tissues, or the blood vessels. Central cord injuries result in a loss of motor, sensation, and even bladder function. Anterior cord injuries reserve bladder function and fine touch, pressure, and vibration, while posterior cord injuries reserve the bladder function with pain, temperature, crude touch, and pressure. So depending on where the injury is, it depends on what you will lose in terms of control and sensation. And then there's Brown-Séquard syndrome, and this is where there's mixed findings of loss of motor function, proprioception, and vibration on the ipsilateral or injured side, and then loss of pain, temperature on the contralateral or uninjured side. So Brown-Séquard is kind of an interesting finding when you see it. Complications of spinal cord injuries include decreased respiratory function, decreased sympathetic cardiac stimulation, so bradycardia and loss of cardiac output, and decreased neuromuscular function distal to the injury. There we see decreased GI motility, decreased GI function, and we'll get impactions, constipation impactions, urinary incontinence, UTI, but then also neurogenic bladder and bowel, so they can either be incontinent or they can retain. Pressure injuries are not uncommon from a decrease in sensation and decrease in movement, and injuries above the level of T7 are at risk for developing autonomic dysreflexia. And this is when there is a painful or irritating stimulus below the level of the injury that causes this unopposed kind of sympathetic response where the person gets flushing, headache, hypertension, bradycardia, as well as sweating below the level of the injury. Surgical repair is done for certain spinal injuries or spinal problems, as well as sometimes for acute spinal cord issues. And it's important for us as nurses to monitor respiratory rate, vital signs, their neuro status, both central neuro and peripheral neuro status, pain. Look at the site, make sure that there's nothing leaking, like you don't want to have like a soaked dressing. That would indicate maybe CSF was leaking, and then signs and symptoms of infection. Also monitoring urinary output because, again, that neurogenic bladder or urinary retention is a common finding after spinal surgery, and the patient can't go home unless they can urinate. If you have like a cheat sheet or something that you take with you into the clinical setting, having something that kind of is a good memory jogger for the dermatomes is helpful. And you can see here I put in some of the kind of mnemonics that people use to remember certain levels associated with cord injuries and what they impact. So let's talk about some neurological problems and how they present. So we're going to start with motor dysfunction. Central motor dysfunction, so seizures, is an uncontrolled, sudden, excessive discharge of electrical activity. And sometimes people will say they had a convulsion, but a convulsion really is an involuntary episode of rhythmic jerking. And it's often seen with generalized tonic-clonic seizures, as we see with like epilepsy, but other forms of seizures exist, including like shaking in just one part of the body or total loss of muscle tone, so they just go flaccid. They might stare off into space, such as an absence seizure, or they may have what we call automatisms, which are repetitive unconscious movements like lip smacking or chewing. Some patients experience an aura prior to the seizure, like a strange taste or smell or sensation, or some patients have triggers to their seizures, such as flashing lights or severe headaches, and actually migraine headaches can trigger seizures. Following a tonic-clonic seizure, there's usually a postictal phase, and this lasts about 5 to 30 minutes. The patient oftentimes is incontinent during the seizure because they have full loss of muscle tone, and oftentimes the diaphragm seizes, so they also were hypoxic during the seizure. So afterwards, they're drowsy, they're confused, they're disoriented. Some patients don't wake up for a while. Other patients wake up like very violent and frightened. The most important thing is providing them a very safe and protected experience. The patient may be nauseated, so airway protection and oxygenation are very important. Children may experience seizures related to sudden changes in core temperature. These are called febrile seizures, and they're usually self-limiting. Status epilepticus, on the other hand, can lead to respiratory failure, significant hypoxia, brain damage, and death. So how do we define that? That's a seizure that lasts more than 5 minutes or back-to-back seizures that occur with no lucid period. So the patient doesn't wake up. They never clear from that postictal phase. If that occurs, then a benzodiazepine should be administered. And if you don't have an IV, you can give Versed intranasally, you can give Ativan, IM, or you can give Valium rectally. And because you can give Versed intranasally and have it work just as effectively and just as fast, that typically is preferred than trying to stick a needle in somebody who's actively seizing or trying to stick a catheter in someone's rectum who's actively seizing, because that also involves having to pull their pants down, potentially in a public area. Assess the eyes after you administer the benzodiazepine for continued seizure activity, because once the peripheral motor activity has stopped from the benzodiazepine, sometimes the brain is still seizing. And if you look at the eyes themselves and they're still beating, like rhythmic jerking of the eyes, then the brain itself is still seizing and you need additional medications. The primary cause of status epilepticus is failure to take anticonvulsant medications. And really, the message is that when you take these, you take them for life. If we're going to do an EEG, we do hold the morning dose of the anticonvulsant, but you're in a controlled setting. We have all of the medication and rescue equipment that we need. And the purpose of an EEG is to actually induce a seizure, so that's okay. New onset seizures in an adult is really concerning because we're worried about a bleed or a mass. And for an adult who's never had a seizure who suddenly has one, they should have an immediate head CT. If nothing is found, then they usually follow up with a neurologist and maybe even an MRI, EEG, testing, things like that. If you're with someone who experiences a generalized seizure, really your goal is to protect their head and their airway. So assist them to the floor if they're standing or walking or sitting. If they're in the bed already, just roll them onto their side, put a pillow under their head or your coat or your arm, whatever, but protect their head from hitting the floor, or if they're in the bed, protect them from hitting the railings. Nothing in the mouth. No tongue blades, no suction, nothing. Do not attempt to restrain someone who's having a seizure. You can actually break bones this way, so this is critical. And have things like suction, oxygen, bag valve mask, those things ready and available in case you need them after the seizure is over. But don't try to do things while the patient's actively seizing because you're just going to end up injuring them. Peripheral motor dysfunction includes things like myasthenia gravis and trigeminal neuralgia. So myasthenia gravis is an acquired autoimmune disorder where the person has this fluctuating weakness that's usually worse as the day goes on, better in the morning or better after a nap. And common signs and symptoms include ptosis, which is drooping of the eyelid, double vision, fatigue, muscle weakness, difficulty chewing or swallowing, and respiratory compromise. So a lot of times it's kind of the upper head, neck, and eye muscles, as well as thorax and truncal muscles that are impacted by myasthenia gravis. The diagnosis is confirmed with tensilon testing, which is edrophonium. This is a really short-acting anticholinesterase medication, so it blocks the effects of the enzyme in the synapse, which allows an increase in acetylcholine, essentially, and this should improve the patient's strength and decrease the ptosis. If it works, then great. They have myasthenia gravis and they get put on a chronic long-acting cholinergic medication. The problem with this, though, is that the patient can develop a cholinergic crisis from a buildup of the acetylcholine in the synapses. And so this looks like that sludge or that dumbbell. So the patient's excessively wet, bradycardic bronchospasm, bronchorrhea, sweating, excessive secretions, pallor, constricted pupils. This can be life-threatening, and the treatment for that is an anticholinergic drug like atropine. If we're not sure if the person's having a myasthenic crisis or a cholinergic crisis, again, we can use tensilon to distinguish between the two. And if the person gets better, then it's a myasthenic crisis, and if they get worse or they don't get any better, then it's a cholinergic crisis, and instead we would treat with atropine. Trigeminal neuralgia is acute unilateral severe pain along cranial nerve 5. And this is often triggered by things like touch or pressure, brushing your teeth, drinking or eating anything that's hot or cold, smiling, talking, chewing, or temperatures, even just temperatures out in the air or the environment. We try to teach the person to do things on the unaffected side, like chewing and talking, drink and eat foods that are at room temperature, and then rinse the mouth if brushing the teeth hurts too much. The treatment is actually anti-epileptic medications, and that sometimes helps, as well as there are surgeries they can do, like a rhizotomy, radiosurgery, which is kind of radiation that goes in and destroys the nerve, and then microvascular decompression. Demyelinating degenerative neurologic problems such as multiple sclerosis and Guillain-Barré destroy the myelin sheath, leading to a loss of motor control. Multiple sclerosis is an autoimmune disorder which leads to a buildup of scar tissue and destruction of the myelin sheath. The diagnosis really is an exclusion after ruling out other possible causes of these symptoms. The classic presentation includes these relapses and remissions of those signs and symptoms like numbness, weakness, especially in one or more limbs, visual disturbances and pain with moving their eyes, balance problems, tingling, pain, electric sensations with movement, a tremor and lack of coordination and unsteady gait, being very fatigued, dizzy, experiencing muscle spasms, and then depression. So these mood disorders, and there's really no cure for this. A lot of their signs and symptoms are exacerbated, or these relapses occur due to stress, viral infections, and fatigue. Medications for MS include interferons and immune suppressants, which slow the progression of the disease, and then muscle relaxants like baclofen or Xanaflex, which decrease spasms. Antidepressants can be used for their mood disorder, as well as physical therapy to maintain balance and physical functioning, and then steroids for inflammation. Stool softeners and laxatives are given because so many patients with neurological problems have bowel issues. Guillain-Barré is an acute inflammatory demyelinating polyneuritis, and usually we see this about 1 month after a respiratory or GI infection. This usually is viral in nature, and it presents as acute symmetrical lower extremity weakness that progresses in an ascending manner. Recovery then is in the reverse order. About 85% of people also have facial nerve 7 involvement, so assess facial expression, and about 40% of people experience respiratory impairment. That leads to the need for intubation or trach and mechanical ventilation. Also assess speech, gag, and swallowing because those cranial nerves can be impaired as well. Non-demyelinating degenerative neurologic problems include ALS, Parkinson's disease, and Alzheimer's disease. So ALS involves the destruction of motor neurons that lead to a total loss of motor function. And we see weakness, stiffness, muscle cramps or spasms, slurred speech, difficulty swallowing. The upper motor neuron damage causes the spasticity, while the lower motor neuron damage causes flaccidity. Treatment really is symptomatic. Baclofen for spasms, stool softeners and laxatives for bowel care, tricyclic antidepressants for things like pain and secretions, and then CNS stimulants for weakness and fatigue. Aspiration is really one of the things we worry about, as well as respiratory failure and pneumonia. Many of these patients will need intubation and mechanical ventilation and even enteral feedings as the disease progresses. Parkinson's disease is a progressive neurodegenerative disease where there's a decrease of dopamine in the synapse, which leads to unopposed acetylcholine activity. So the 4 hallmark signs of Parkinson's disease are resting tremors, muscle rigidity, so like kind of stiff muscles, and then bradykinesia, which is like this slow movement, and postural instability, which makes them at high risk for falls. And so, you'd think about kind of the classic sign of this shuffling gait, but they have these really stiff legs with this slow movement and kind of a wide shuffling gait because they have this postural instability. Drugs that are used to treat the symptoms of Parkinson's include dopamine receptor agonists that increase the dopamine activity at the synapse, and then levodopa, which turns into dopamine in the brain. Drugs like carbidopa stop the breakdown of levodopa in the periphery, and then COMT drugs help perpetuate the activity of levodopa in the brain. Eventually, as the disease progresses, they lose their gag reflex and the swallowing is impaired. This means that nutrition is going to decline, cognitive dysfunction occurs, and Lewy body dementia can develop as well. And as I said, Parkinson's disease is a fatal disease. Alzheimer's disease, also sometimes referred to as Alzheimer's dementia, is a form of dementia with gradual loss of brain and memory function. And basically, the normal neurologic system in the brain is being replaced by these plaques and tangles. Short-term memory loss is really kind of the first sign, but they're still able to care for themselves. And then later they experience trouble, problem solving, they lose their long-term memory, and then their self-care abilities. Aricept may help increase memory and learning, but it does not slow the progression of the disease, where Namenda reduces the speed of neuronal destruction and kind of delays death. Safety really is our primary concern with patients with Alzheimer's. It's important that we institute the least restrictive but protective measures like hourly rounding or frequent checking, place them in a place where you can see them, so line of sight or near the nurse's station, use bed alarms, rise alarms, safety measures in the room, the brakes on, the bed in the lowest position, pads, whatever your facility allows. Clear any obstacles out of the way. Provide a toileting schedule so that they're not getting up unattended, trying to go to the bathroom, and don't leave them alone or unsupervised. And remember that you use the family or visitors as part of the care plan. So if they're there visiting and they're watching them, make sure that you tell them to let you know when they leave so that you're sure that somebody else is keeping an eye on them and they can stay safe. Infectious disorders of the brain include meningitis and encephalitis. So meningitis is an inflammation of the meninges, or kind of the lining around the brain, and that can occur from infection, medication, cancer, or after surgery. These infections can be bacterial or viral, and then the cancerous tumors can cause irritation or even perforation of the meninges. The most common signs and symptoms are fever or rash if it's bacterial, and then all of them present with headache, stiff neck, and photophobia, which is a sensitivity to lights. When we do a lumbar puncture and analyze the CSF, if it's bacterial, we'll see an increase in protein, a decrease in glucose, and positive white blood cell count. All patients with meningeal irritation will have a positive Brudzinski's sign as well as Koenig's sign that tell us that they have this meningeal irritation. Treatment really depends on the underlying cause, but if it is bacterial, make sure that you institute droplet precautions. Encephalitis is usually caused by a viral infection like West Nile, Lyme, or herpes. And in encephalitis, the brain tissue is inflamed, causing damage that can lead to permanent neurological dysfunction, increased ICP, or even death. Common signs and symptoms include headache, phonophobia, which is sensitivity to sound, nuchal rigidity, fevers, altered mental status. Again, Koenig's and Brudzinski's may be present because of irritation to the meninges. Cranial nerves 3, 4, and 6 may also be impaired, and those are the ones that we're checking when we check extraocular movements. So the person may have pupillary dilation and then deviation of the eye itself, usually down and out if there's like one side of the brain that is infected or impacted. General considerations for our ABCs and applying those to the neuro patient. Safety is always primary concern. Monitor those neuro assessments frequently and watch for the subtle changes because things like loss of airway and seizures, confusion, combativeness can occur suddenly. Seizure pads should always be placed on patients who have sodium imbalances, increased intracranial pressure, or a history of seizure disorders. Use good nursing judgment to make the environment safe for your neurologic patients. Airway and breathing should be always at the top of your thought process. Have the appropriate sized equipment ready for oxygen, ventilation, suction, intubation, and tracheostomy if indicated, remembering that any high C-spine injuries have an increased risk of loss of the phrenic nerve and therefore loss of autonomous respirations. So C3, 4, and 5 keep the diaphragm alive, and if you have an injury in your C-spine, you are at greater risk of losing your ability to breathe independently. Also, all those degenerative disorders have the risk of losing your ability to breathe independently. So just think about, what do I need to have in the room to care for this patient? Things like maintaining the head of the bed at 30 degrees, aspiration precautions, avoiding straws, things like that. Those are just routine nursing interventions that you should apply to every patient who has an increased risk for aspiration or airway compromise. Circulation. So maintain adequate blood pressure to perfuse the brain. Hypotension is life-threatening with increased intracranial pressure. If you have an increased intracranial pressure, your cerebral perfusion pressure requirements increase. Therefore, your blood pressure needs to increase, and that is why your blood pressure increases with Cushing's triad with increased intracranial pressure. We do not want to decrease the blood pressure to the point of hypotension or to the point where it's so low that the cerebral perfusion pressure is less than the intracranial pressure and you can't actually perfuse the brain. Administering stool softeners to prevent bearing down and that reflex bradycardia and loss of cardiac output is really critical and essential to the patient who has a head injury or increased intracranial pressure, but also important for a lot of these patients that just have meningitis, encephalitis, and any of these neurologic degenerative diseases. They have a loss of function of, that parasympathetic control of their GI tract. And then disability applies to neuro. So again, monitor neuro assessments frequently. Yes, I said that twice. Asymmetry is not normal unless it is. And so you got to know that baseline, right? Think about the person who has anisocoria. So at baseline, they have unequal pupils. So it's so important to know, was that there before or not? And that is it. So thanks for watching. I hope this helps you, and take care.